Hi, good morning, everyone. So welcome back to the 23rd Medical and Health Research Week 2021. So I hope that all of you have learned a lot of things and benefited from our modules and lectures over the past 2 weeks. So I'm Dr. Tan, the moderators for today's module. So in this module, we received several dozens of abstracts for poster presentations, and we shortlisted 9 posters which we think have the highest scientific merit for oral session today. So each presenter is given 15 minutes, which comprises 10 minutes of presentation, followed by a Q&A session. So for the Q&A session, we have decided that only the judges should ask questions. And the 10-minute presentation is actually pre-recorded. So the technical team will play the pre-recorded videos shortly, and then followed by the live Q&A session, where all the presenters are here and they'll be answering the questions from the judges in person in real time. So today we are very lucky to have 2 very esteemed judges with us who are very experienced in preclinical research. So the first one is Associate Professor Dr. Nur Fazila Ahmad from the Department of Community Health, Faculty of Medicine, UKM. And the second judge is Associate Professor Dr. Lau Tet Yu from the UKM Medical Molecular Biology Institute. So thank you very much, Prof. Fazila and Prof. Lau, for the willingness to join us today. So without further ado, let us listen to the presentation from our first presenter, Nurul Izzat Ibrahim, with a title, The Effects of Maranthor's Pamilum Va-alata Extract on Wound Reduction and Hydroxyproline Content in Burn Wound Rat Model. So the technical team, please play the video.
Assalamualaikum and a very good day to all. I'm Nurul Izzat, who would like to present the findings of our research entitled The Effects of Maranthor's Pamilum Va-alata Extract on Wound Reduction and Hydroxyproline Content in Burn Wound Rat Model. Burns can be considered as one of the most serious conditions in emergency medicine, which results in physical, psychological, and chronic disabilities. Silver sulfadiazide is the gold standard topical burn treatment, but it was reported to be toxic to keratinocytes and fibroblasts, which may turn in delaying the wound healing process. Potential agent, Maranthor's Pamilum Va-alata aqueous extract, or has been known also as the Kacip Fatimah and Labicia pumila, has been associated to improve minor wound healing in a postmenopausal rat model. However, its effect on the burn wound healing has not yet been done. Therefore, the objective of our research was to determine the healing effect of the extract on thermal burn wounds in rats. So in our research, we used a different model, which is the thermal burn wounds in rats. As for the methodology, we have used 50 scrap-dolly male rats, and they were divided into 5 groups. The first group was normal control. The rats were left untreated. The second group was negative control, in which the rats were given ointment base. The third group was positive control, in which the rats were given 1% silver sulfadiazide, and the fourth group was MPVA leaf, in which the rats were given 2% of the leaf extract. And then the fifth group was MPVA root, in which the rats were given 2% of the root extract. After we divide the rats were induced with burn wound. There were 4 wounds were created on each rat like this. And then the burn wound, we used heated steel rod at 80 degrees Celsius for 10 seconds. This means that we hold the heated steel rod for 10 seconds onto the skin of the rat to induce the burn wound. As for the wound treatment, the treatment was given accordingly to the groups for 3 weeks. The treatment was given approximately 0.1 gram per wound topically. And then within the 3 weeks, we measured the contraction of the wound starting from the day 0, 3, 7, 14, and 21. And for the hydroxychloroquine content, we have excised the wounds on day 14. As for the results, the wound contraction measurement, we can see that on the day 7 onwards, both of the leaf and the root extract groups have shown a significant reduction for the wound contraction. Meanwhile, for the hydroxychloroquine content, we can see here that only the leaf extract group was significantly higher when compared to the normal control and negative control. As for the discussion, remarkable wound contraction of MPVA might be correlated with the collagen content. Collagen deposition is important to increase wound strength, control cell shape, and differentiation. MPVA leaf extract had better collagen content when compared to the root extract, which might be due to the superior antimicrobial effect. The content of silver content component in the positive group causes cytotoxicity, induced oxidative stress, and DNA damage in skin cells. As for the conclusion, both the leaf and root extracts of MPVA could promote the healing of thermal burn wounds, with leaf extract was superior in terms of the hydroxychloroquine content. These are some references that have been used in the study. So thank you.
All right, thank you, Nurul Izzah. So now we open for the Q&A sessions. Any question from the judges?
Okay, thank you, Nurul Izzah. Congratulations, it's a clear presentation. It's just that I would like to ask about your discussion, the last discussion about you remember the fourth, I think about the positive control. How do you come up with that discussion? Because it's not one of the findings in your study. It's from literature, but how do you relate to your study?
You mean that why I use the silver sulfadiazine as a positive control?
No. It is a positive control, but you discuss it as if it's a cytotoxicity, but how do you relate it to your study? Is it a finding in your study?
Oh, okay. Because when we compare with our treatment, it seems that our treatment is better. So that's why I'm comparing with the silver sulfadiazine. Because our extracts have better effect compared to the silver sulfadiazine.
Because it was compared to the negative control, right? Fine. But then you conclude or sort of you discuss on the cytotoxicity of the SSC. That is from literature, but it's not one of the findings. Did you find the toxicity in your study? Did you test it?
No, Prof.
No.
Didn't
Fine.
read. Yeah.
Okay, for conclusion per se, how would you proceed after this? What would be the future plan? You have a findings, you have some impacts out of study. So what would you do? How would you proceed further after this? In any study, there must be some plan for future study.
For future study, maybe we will proceed with the clinical trial. Maybe we will proceed on the burn wound in patients.
In patients.
Yeah.
Okay, that's all from me. Thank you.
Welcome, Prof.
All right, thank you very much. So now we shall move on to the next presentation by Ahmad Musad bin Ahmad Hariza with the title, The Fabrication of Gelatin Elastin Nanocellulose Composite Bioscaffold as a Potential Acellular Skin Substitute.
Assalamualaikum and a very good day to everyone. My name is Ahmad Mus'ab bin Ahmad Hariza. I'm a master's candidate for the Physiology Mixed Mode program, and this is my study entitled The Fabrication of Gelatin Elastin Nanocellulose Composite Bioscaffold as a Potential Cellular Skin Substitute. My main supervisor is Dr. Muhammad Haikal Muhammad Yunus from the Department of Physiology. I'm also co-supervised by Dr. Jaya Kumar Murthy from the Department of Physiology and Dr. Muhammad Fauzi Muhammad Busra from the Center for Tissue Engineering and Regenerative Medicine. As an introduction, gelatin is a viable alternative to collagen as a material for developing porous biological scaffold in the management of chronic wounds, as it possesses desirable properties such as good biocompatibility and low antigenicity. However, gelatin is structurally weak and it requires the incorporation of other materials to provide stability to its structure. A common method is to use cross-linking agents such as a genipin. So for this study, we aim to fabricate and characterize the physical properties of a composite bioscaffold comprising of gelatin, elastin, and nanocellulose cross-linked with genipin. For the study, all of our materials are obtained from natural resources. The gelatin are derived from bovine sources, elastin from poultry skin, and nanocellulose extracted from oil palm fruits. Both gelatin and elastin are fixed at a concentration of 5% and 0.2% respectively. After mixing all of these materials together, they underwent a process known as freeze drying and were subsequently cross-linked with genipin at 0.1%. The composite bioscaffold groups comprise of gelatin, elastin, and nanocellulose at an increasing concentration of 0.01%, 0.05%, and 0.1%. Pure gelatin scaffold was set as the control. There's also another group comprising of gelatin and elastin only. All of these are then subjected to physical analysis according to the parameters given here. Porosity analysis indicated an upward trend of increasing porosity with increasing concentration of nanocellulose. The group with the highest concentration of nanocellulose showed significant difference when compared with the control. For biodegradation analysis, increasing nanocellulose concentration reduced the rate of weight loss per hour. As indicated by the graph here, the group with the highest amount of nanocellulose showed significant difference when compared with the groups comprising of gelatin and elastin. Finally, analysis of the scaffold swelling capacity indicated an increasing nanocellulose concentration that reduces the capacity of the scaffold to absorb water. The group with the least amount of nanocellulose at 0.01% showed significant difference when compared to both the control and the gelatin and elastin groups. The group with 0.05 concentration of nanocellulose showed significant difference when compared with the control. In conclusion, these preliminary studies showed that the fabricated composite bioscaffolds possess the desired physical characteristics and is a potential candidate as a skin substitute. Thank you very much for your attention.
All right, that's the presentation by Ahmad Musab. So any question from the judges?
Okay, just one question for me. Thank you, Ahmad Musab. Very good presentation. Would you say your findings is in concordance with previous study, or is your study is novel? How would you say that?
In terms of findings, I would say that it's quite different from a previous study that uses collagen combined with a gelatin, because in terms of, for example, the swelling capacity with increasing nanocellulose concentration, it causes an increasing in swelling capacity. However, from this, from my study, by increasing the cellulose concentration, it reduces the capacity of the gelatin-based scaffold to absorb water. So I can say that's quite a discrepancy by using a gelatin as in gelatin-based composite as a substitute for collagen-based scaffold. And in terms of novelty, because this study is we incorporated now natural-based materials, halal-based gelatin actually, because previous study had been using gelatin from porcine sources. So yeah, we use this first try this gelatin-based, try to stabilize the properties of this halal-based gelatin.
Thank you. Okay, thank you, Rekta. Thank you, Ahmad Musab.
Okay, so if there is no more question, then we move on to the next presentation by Muhammad Mustazil Muhammad Noor with the title Effect of Gel on Body Composition Changes in Postmenopausal Osteoporosis.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very good morning to everyone. My name is Muhammad Mustazil Muhammad Noor. Today I will present about effects of gel on body composition change in postmenopausal osteoporosis. In postmenopausal women, estrogen deficiency alters body composition by decreasing muscle mass and bone mineral density. We know that estrogen is a female hormone which commonly associated with the female body and have a big role in maintaining health. When women get menopause, their estrogen level will reduce and height in body fat will leading to obesity. Gel is a traditional Chinese medicine high in collagen content and is used to nourish the blood as well as promote bone and joint health. This study aims to evaluate the effects of gel on body composition of rats where estrogen deficiency induced by ovarectomy. This is the methodology. We use 48 rats, 3-month-old female spark dolly rats, were divided to 6 groups. sham, negative control, positive control, low dose of hijau, medium dose of hijau, and high dose of hijau. Ovarectomy was performed on all groups except the sham group. Sham and negative control received tap water orally. Positive control received 1% of calcium in drinking water. Low dose of hijau received 0.26 gram per kg. Medium dose of hijau received 0.53 gram per kg. And high dose of hijau received 1.06 gram per kg. After 7 days of ovarectomy, we start treatment of hijau and calcium for 2 months. Then dual energy X-ray scanning or DEXA scanning was conducted at baseline at 1 month and 2 months. This DEXA scanning is to determine their body composition, include total mass, fat mass, and body fat percentage. So here the result. We can see the result show that ovarectomy induced a significant increase in total mass, body fat mass, and body fat percentage. But this was not observed in the sham group. We see that high dose of hijau and calcium supplementation prevented increase in body fat mass and percentage in ovarectomized rat. So here the discussion I already mentioned, and based on the result, we can conclude that high dose of hijau supplementation can prevent the increase in body fat due to estrogen deficiency. This is the reference, and I would like to thank you University Kebangsaan Malaysia for the fund and Dr. Jin Kian from Zhejiang University for providing the hijau for this project. Thank you.
All right, thank you, Muhammad Mustazil. Now we open for the Q&A session. Any question from the judges?
Where's the presenter? I want to see the presenter.
All right.
Okay, thank you very much. I think I heard from your presentation, you mentioned calcium as well. To increase in total mass, is it? But which one? I didn't see it in the slide or the result. Which section, or did I miss it? Because it's a bit small. Do you have the slides? And I understand from your graph. Okay, yang hitam-hitam atas tu is the one you want to indicate the significant, right?
Okay.
Okay, but I don't see it in the calcium group. So is that one of the findings?
Oh, actually based. Okay, so Assalamualaikum and good morning to everyone. Before I start, I would like to thank you to Chairperson and Prof. Dr. Nur Fazilah. Okay, my name is Muhammad Mustazil Muhammad Noor. I'm PPSP from Pharmacology Department. And actually, in this study, we see that calcium and hijau in high dose is prevented increase in body fat due to the estrogen deficiency.
calcium as well. So how would you say your findings compared to previous studies, previous literatures? Because there's a bit limited in discussion. You just present the result. Would it be the same?
Actually, yes. This is the minor, and then we will continue the next study in the osteoporosis due to the EGL.
So interesting. Okay, that's all from me. Thank you.
Okay, thanks, Prof.
Thank you, Mr. Mustazil, for sharing your research with us. So my question is, this e-gel is actually a traditional, a form of traditional Chinese medicine, right? So is it from plant source or from animal source? And also, given the e-gel that's provided to you, one problem with this traditional herbal or animal-based medicine is that the difficulty to control the batch to batch differences. So for example, the e-gel you got for this batch maybe have an effect in reducing the fat in the animals, but then in the next batch probably it will be contaminated with heavy metals and things like that. So how do you make sure that the e-gel you get is like, is well controlled from batch to batch differences? And also I want to know whether it's from plant or animals or what is. Yeah.
Okay. Thanks to Dr. Loh Teck Yew. Okay. Yeah. Actually, the e-gel ni, the e-gel we get from the Dr. Jing Jiang from the Dr. Xing King from the Zhejiang University. Then the source of the e-gel is one particular animal. It's a donkey skin.
Oh, donkey skin.
Yes, donkey skin. We know that e-gel is means traditional Chinese medicine that Chinese community used in 400 years. 400 years. Then we get from the Dr. Zhejiang, Jingqian, and then we try to the animal to know whether the e-gel is can reduce the prevent the increase in the body fat of animal lah.
So in the traditional Chinese medicine, what is it used for?
Actually it's used to the skin, beautiful the skin, and then strengthen the bones.
So it's a
then because e-gel is rich of calcium contents, collagen content.
Okay. Thank you.
All right.
Okay, thank you, Muhammad Mustazil. So now we shall move on to the next presentation by Tan Zheng Kiat with the title Comparison of Lipid Extraction Protocols for Plasma and Tissue Using Liquid Chromatography Mass Spectrometry.
Very good evening here to audience. I'm Tan from UKM presenting my work entitled Comparisons of Lipid Extraction Protocols for Plasmas and Tissue Using Liquid Chromatography Mass Spectrometry LCMS. Lipidomics is the study to quantify and identify lipid species in cells or tissues. The workflow consists of expanded design where you have, like for example, two groups, disease and healthy, and then sample preparation involving extract and separate the lipids from the aqueous metabolite or the so-called polar metabolite, followed by data acquisition using appropriate instrument, for example, LCMS, and then data analysis using chemometric software, and finally making meaningful interpretation related back to the study. Lipidomics has been applied to for biomarker discovery and mechanistic study for various diseases, and also for drug discovery and dietary interactions. Therefore, there has been increasing trend in publication for lipidomics. more than 500 lipid species has been detected or reported in human plasma. However, one of the challenges in lipidomic study is to extract and to detect the lipid structure with various structures and therefore the physiochemical properties. Therefore, this study was aimed to compare the effectiveness of 4 different lipid extraction methods for plasma and tissue using LCMS. The brain tissue and the plasma were obtained from the rats and spiked with the commercially available internal standards. 4 different extraction methods consist of Foch method, Blythe-Dyer methods, and MTB and Bumy methods. MTB and Bumy are referring to the specific reagents that used in the method, while Foch and Blythe-Dyer are the traditional extraction methods using a mixture of organic aqueous and polar solvent. For Foch and Blythe-Dyer, it is further the 2 different organic solvent, which is the chloroform and dichloromethane DCM, were further compared. Take note that the first 3 methods, they're actually a bi-layer extraction, meaning that the lipid will be separated from the aqueous or the polar metabolite, depending on the solvent used, whether it's upper or lower phase. The extract will be reconstituted with a methanol and isopropanol mixture in 1:1 ratio, and then acquired by the LCMS and pre-processed and analyzed by the MS Dial and Metabo analysts. The most suitable method will be chosen for further evaluation, and in this case is the Foch DCM method. First, different reconstitution buffer was compared, whether it is isopropanol alone, isopropanol mixed with methanol, or methanol alone. Second, different extraction methods were compared, whether it is single extraction method or double extraction step. Double extraction means the lipid bilayer will transfer to a new tube and re-extract with the solvent. And lastly, since this is a Foch method, the aqueous layer of the Foch method, which consists of the polar metabolite, was compared with the standard metabolomic extraction using 80% methanol for the metabolomic profiling study. Each column in the heat map represents the overall signal intensity for different extraction methods. All methods show relatively satisfactory signal, except for the MTBE in the plasma. For the tissue, the organic solvent dichloromethane, whether it is the Foch or the Blythe-Dyer methods, was the most efficient. Looking at the specific signal intensity for the internal standards, Foch method, whether it's using the chloroform or dichloromethane, and the Bumy method was resulted in higher intensity or recovery. Therefore, the Foch method with the DCN organic solvent was due for further evaluation. Looking at the different reconstitution buffer, isopropanol alone or the methanol alone resulted or generated in a specific group of lipids with a lower signal, but in an opposing manner. The mixture IPA and methanol 1:1 ratio resulted in an intermediate signal. There is no lower or less lower signal. Single extraction step had more lipid with higher intensity than double extraction method, at least in the positive ion modes. Metabolomic profile using aqueous phase of the Foch method and the standard metabolomic extraction method resulted in a similar metabolomic profile, except for some metabolite, for example, purine and pyrimidine nucleotide are enriched in the Foch aqueous phase, whereas the polar lipids, for example, LPC, LPE, are enriched in the standard metabolic extraction. This is not surprise for the standard metabolic extraction, the left panel, because the polar lipid was partitioned into the lipid layer for the Foch method already, so it will not show, or it will be not shown in the aqueous extract. So in summary, by using the Foch DCM method, a total of more than 800 and 1,300 lipid species has been detected in plasma and tissue respectively, which are correspond to 26 and 33 lipid subclasses. LPC, PC, Acyl-glycerol, phosphocholine, acyl-carnitine, diacyl-glycerol are enriched in the plasma and the tissue. In contrast, cholesterol and steroid ester were enriched or predominant found in the plasma, whereas acyl, atenomine, PS and LPS were enriched in the tissue sample. In conclusion, all methods cover a broad range of lipid classes in the sample, but with different signal intensity. Foch method with DCM was the more effective lipid extraction protocol for plasma and tissue due to higher recovery rates in terms of signal intensity. Bumy method was as efficient as the Foch DCM method, at least for plasma. However, Foch method has the advantage because it is a biphasic layer that allowed for lipidomic and metabolic profiling to be conducted from the same sample. The current finding could be used as a reference for future study when considering extraction for lipidomic study. These are the references for this presentation. Finally, I would like to thank my co-researchers and the grant sponsor, and thank you for your attention.
All right, thank you, Jenkit, for the presentation. So now we open for the Q&A session. Any question from the judges?
Thank you, Dr. Jenkit, for your nice presentation. So my question would be the 4 different extraction method, right? Based on the heat map, do you think that is there a bias for the subclass of lipids that has been purified with these different methods?
Yeah, at least for the last 2 methods, the MTB and the Bumy method, we found there is a specific class. For example, for the I have to check. Sorry, in the poster it shows TG. Okay. For example, MTB method, they specifically amplified the diacylglycerol lipid subclasses, but just I would not say a large major, but there is a specific amplification or the enrichment. Yeah.
Yeah. So, and also according to your reference, right? The first 2 methods, the Foch method and the I don't know what method. The first 2 method is published in 1950s, and the last 2 method is published in 2018 or so, right? So why is it that the Foch method is so good that as you mentioned, but then it seems like the reference is quite old, and then has this method been widely used in the current lipidomic studies?
The first 2 methods is the gold standard in the field, which has been more than 60 years and still existing. But as you know, this is the untargeted profiling. There is no single method that can enrich or detect or extract all the lipid subclasses. So we always look for the best method that's suitable for our samples and our instrument.
Okay.
So the last two methods, the MTB and the BUMI, they are the new method because they are like the last method. The BUMI is the single extraction method. That means they have a single phase. For the MTBE, it has an advantage because the lipid phase is in the upper phase. So of course, we see that there is a less contamination that we say because it's the upper phase, you can transfer from the upper layer.
Yeah. Thank you. I hope I'm not asking too much. My last question. So, so according to you, the Forge method is the best, and then from plasma you get like 800 species of lipid, right? And then from the tissue you get around 1,300, right? So then, if you combine the four method, what is the total lipid that you can get from the plasma and also the tissue? Do you get much more than 800 and 1,300? So that means that might be complementary, the extraction.
Yeah, good question. We didn't compare. It was beyond the objective, but we will look into that in the future to see the Venn diagram, what is the complementary and what is the differences and similarity.
Because if that increase the total lipid class that can be identified, then that may be very interesting, right? If you can get more than 1,300. If you apply two or more methods. Yeah. Thank you very much.
No further question because I wanted to ask about the reference now, but it's okay. Thank you. Okay,
thank you very much. So now we shall move on to the next presentation by Eileen Lau with the title Development and Validation of Early Intervention Guidebook in Dressing for Children with Autism Spectrum Disorder in Malaysia.
Good day to everyone. Today, I'm going to present the finding of my final year research entitled Development and Validation of Early Intervention Guidebook in Dressing for Children with Autism Spectrum Disorder in Malaysia. So children with autism spectrum disorder is often reported to have delayed achievements of developmental milestones in dressing activity. Early dressing training has been encouraged to facilitate them to attend dressing skills at later milestones. A comprehensive guideline is still lacking to systematize and conduct the dressing training for children with ASD in the early stage of life. So the objective of my study was to develop and validate an early intervention guidebook in dressing for 18 to 36 months old children with ASD in Malaysia. So my study consisted of two phases. Phase 1, development of the early intervention guidebook. Phase 2, validation of the early intervention guidebook. In phase 1, the guidebook was developed in Malay language. Target audience for this guidebook is parents or caregivers of children suspected and clinically diagnosed with ASD aged between 18 to 36 months. There are 5 domains included in this guidebook. First one, introduction. Second, common dressing problem. Third, strategies to assist in dressing. Fourth one, suggestions on adaptive equipment. And the last one is safety measures. The pre-validation version guidebook consisted of 32 pages with the front cover, table of content, and a brief introduction about this guidebook. So moving on to phase 2 of this study, it consisted of 3 components. First one, focus group discussion session. Second one, phase and content validation process. And the third one, cognitive interviewing. So to conduct FGD sessions, 9 expert panels with background of occupational therapy, with at least 5 years of working experience in pediatric settings and are literate in Malay were recruited via purposive sampling method. The FGD session was held for 1 hour using Google Meet in Malay language. Qualitative thematic analysis was used to organize the response data into categories systematically, and the guidebook was then revised based on the expert's comment. So moving on to the phase and content validation process, some group of experts was recruited for them to involve in this process. Phase validity related to appropriateness of the font size and font type, suitability of content arrangement was assessed in a dichotomous rating scale with the option of yes and no. An instrument was deemed to have adequate phase validity if the item obtained a level of agreement of at least 75% positive responses. So To assess content validity of this guidebook, a validation form was prepared and the domains of the guidebook were equated to the evaluative items in this form. The experts were required to rate on the item in the validation form based on 4 criteria, which are relevance, clarity, simplicity, and ambiguity, and in a 4-point Likert scale. So item or content validity index, ICVI, proportion, which means proportion of expert panel members giving an item a rating of 3 or 4, SCVI average, and also SCVI universal agreement were calculated. And an instrument is having high content validity provided that it is constructed by the items having ICVI greater than 0.78, SCVI average greater than 0.90, and SCVI universal agreement at greater than 0.8. So last one, cognitive interviewing. Parents or caregivers who have children clinically diagnosed or suspected with ASD aged between 18 to 36 months old and they can understand Malay were recruited via purposive sampling through Autism's family support group in Facebook. So those parents with severe psychiatric disorder or cognitive impairment, or the children having a physical disability, genetic disorder, or severe medical condition were excluded. So initially, there was 5 parents agreed to participate in cognitive interviewing process. However, due to time constraint and also difficulties to adhering to this study, there was only 3 parents who were willing to involve in this cognitive interview. So 1 hour cognitive interviewing was carried out with participants individually through Google Meet or Zoom. So using the SAM analysis method, which was qualitative thematic analysis to organize the response data into categories systematically. And the guidebook was then again improvised again based on parents' comments. So now I will show you the result of my study. So the first one is about the findings from the FGD session. So there are 4 major themes emerged from this from the findings of FGD session. First one, physical appearance of the guidebook. So from the original title training module on dressing activity, the experts suggested that we need to replace the word training module into guidebook and also include the main user of the guidebook in the title to attract the attention of the main user. So that's one, they suggested that the font type should be in Arial and the font size should be in 12. So they also suggested that more pictures should be used for information sharing. The second theme was arrangement of content. Visual presentations such as table, bullet, and mind map should be used to organize the informational text. And the points in each domain should be arranged in a way to help the readers to able to understand how to conduct the dressing training step by step. For the third thing, appropriateness of the content. So the irrelevant information to the content of children with ASD aged 18 to 36 months was suggested to be excluded, and extra information such as complete and detailed task analysis of for each dressing task, steps to differentiate the front and the back of the t-shirt, strategies to conduct dressing training in play context, and the recommendation of adaptive tools that can be easily found at home. This information is required to be added add on. And for the last theme is the appropriateness of the terminology used. So layman terms should be used so to prevent the miscommunication and also to help the readers to understand it for the easier understanding. So moving on to the findings from cognitive interviewing, 2 emerged themes were information adequacy about strategies to assist, and the second one, the quality of the illustration. So the parents suggested that we should recruit a professional illustration for drawing to ensure the quality of the illustration. So these comments has been adapted and also included in the latest version of the guidebook. So moving on to the result of validity and content validity. So for the result of validity, all the experts were in total agreement on phase validity of the guidebook, indicating that the guidebook obtained a sufficient phase validity. So for the based on the result of content validity, ICVI was ranged from 0.89 to 1, indicating that all the items in the guidebook were judged valid since they all fulfill the minimum criteria of the content validity. So for the overall content validity of the guidebook, the results indicated that the guidebook has a high content validity, as the SCVI of the guidebook was scored full in relevance and simplicity criteria, and while for the clarity and ambiguity criteria, the guidebook contained SCVI average at 0.98 and SCVI UA at universal agreement at 0.80. So for the overall content validity of the guidebook, they also fulfill the minimum criteria of the content validity. So that's why this guidebook was considered to have high content validity. So from this study, in conclusion, these findings provide support that this early intervention guidebook in dressing can be a valid instrument in systematically implementing dressing training and promoting the dressing independence among children with ASD in the early stage of life. So that's all from me. Thank you.
All right, so that's the presentation by Eileen. So now we open for Q&A session. Any question for the judges?
Thank you, Eileen. For the development phase, okay, you came up with a thematic analysis. Any specific, how did you conduct this analysis?
So for the thematic analysis method I use to analyze the main thing emerged from the FGD results. So how is it conducted? So first of all, I will normally after if after the FGD session had conducted, actually we had recorded the session. So actually we were that time we rewrite the transcript up, and then we reread the transcript for several times, and then determine the main points from the transcript. So after that, after we had determined the key data, and then we will regroup them again according to the similar features. Yeah, so that's the general about the thematic analysis method that conducted in my research.
You did it manually. You're not using any software like NVivo or so on.
Not manually in terms of writing, but we just type it out after we listen to the recording during the FGD session, then we just type it out.
Okay.
So yeah,
does not involve any software.
Yeah, no software involved.
As for the mothers, 3 parents, is it parent or parents?
It's parent only, 3 parents.
Parent only. What were the age of the children and the spectrum? Do you know the spectrum of the disease of the? Autism is a spectrum, right?
Yeah. So actually, for my research, just focus on the children with ASD from 1.5 years old to 3 years old. Okay. Yeah. So for the parents that we
3 parents.
Yeah, just only have 3 parents. So their child will just in the strength that we had determined. Just 1.5 years old and until 3 years old.
Do you know the extreme of the disease spectrum of their children? Because that might affect their opinion, you know.
That one we didn't like include in our study. Yeah. So means that my research is just like include all the spectrums. Maybe this one I need to further think about it, that the spectrum might affect the result. Yeah.
Yeah, the spectrum of the disease or the, you know, because different spectrum will have different perception or experience to the parents, so they will give different opinion, right?
Okay.
So maybe you need to, you know, just detail that a bit later in your writing, so on. Just describe these three parents. Okay. Thank you.
All right, if there's no more question, then we move on to the next presentation by Naufa bin Nordin with the title, The Effect of Reduced Visual Functions on Visual Motor Integration Skills in Preschool Children.
Assalamualaikum warahmatullahi wabarakatuh, and very good evening to all the judges. My name is Naufa bin Nordin, and I will be presenting my research, which is titled The Effect of Reduced Visual Function on Visual Motor Integration Skill in Preschool Children. Okay, so visual motor integration, or abbreviated as VMI, it actually refers to the ability to which visual perception and motor coordinations are well coordinated. So how well someone uses both the components, the vision components and the motor components to do a task. So this involves a lot of learning related tasks such as reading, writing, your handwriting quality, and arithmetic skills. So all of these are actually learning related activities, very functional for children who are entering primary school or mainstream school. So the next thing is visual function. Visual function is, you know, how sharp your vision is. So there are three main visual assessment that we focus on, which is distant vision, near vision, and stereo acuity. Okay, so in our situation, Malaysia, usually they do regular vision screening checkup. So eye checkup or vision screening checkup in the primary school, when you enter a government primary school, they will have at least like 3 times eye checkup, and usually they only screen for distant vision and they will ignore the near and also the stereo acuity, which those two components is actually as important as distant vision, because past report shows that visual demand for near task and for like really 3D perception is similar with distance. So you have to actually do 3 assessments, not only distant vision screening. Okay, so obviously this visual function is important for children because they have to see sharp whenever they want to learn something, like copying from a blackboard or just simple motor skills. So all of these are actually really important for your development. Okay, so we want to see, since Malaysia do regular eye checkup regularly, but for the VMI, it's still not yet fully explored. It's only done by, you know, psychologists or occupational therapists whenever they wanna, whenever they receive like children with, you know, delayed or learning related problems. So, but we want to use this opportunity to study how VMI is actually should be included in the, you know, normal regular screening for normal children, not only for children like autistic children or like learning problem or slow learner children. So okay, so the problem statement is we want to see someone who failed in the vision screening, whether they should also screen for VMI, because we want to see the effect of the VMI. Okay, if there is any differences between, so the objective is there is any differences between the BD VMI scores on children who failed the vision screening and those who passed their vision screening. And then the second objective is to see the effects of the reduced visual function on the performance of the BMI. So since Malaysia always do regular eye checkup, we want to see if the one who failed the eye checkup, they not only should be corrected with glasses, they also should be screened with VMI, which is using the BB-VMI instrument. And then the hypothesis, suboptimal visual function as usually discovered in children with failed vision screening, who failed vision screening would affect their VMI skill. We would expect someone who failed in their vision screening would also have an effect in their VMI skill measured using the BB-VMI. So this research is a quantitative research, okay? And we calculate our sample using the Gracie Morgan, and with including the 10% dropout rate, we found that around 480 to produce a high enough effect size. So our research involved healthy preschool children aged 60 to 83 months old from various socioeconomic backgrounds, meaning that we want to involve preschool children because preschool children is actually the critical age for someone to intervene or someone to correct whenever they have developmental delays. Because when the child already enters the mainstream school, they already exposed to a lot of stuff. So it's going to make things difficult if you want to intervene them or you want to give an training or somewhat. So they study, the location for the study is Klang Valley, which is Kuala Lumpur, Ampang, Gombak, and Sepang. And then for the procedure for the study, okay, so first we did distant vision, and then we did the near vision, and then lastly is the stereo acuity. This is for the vision screening. So the criteria for pass and fail for distant vision is 0.3 logMAR, for near is 0.4 logMAR, and for stereo acuity is 300 arcsec. Okay, so for the child who classified as failed vision screening is the child who failed in at least one of the 3 vision assessment being done. And then the last test is the visual motor integration. So VMI is assessed using the BB-VMI, which is an instrument, a booklet, which usually being done and is commonly being done by psychologists, educators to help screen children with learning problems. Okay, so the result, we have screened 435 children and with mean age of 71 months old, so around 5 to 6 years old, and around 47% of them were girls, 53% of them were boys, and for the ethnicity, majority of them were Malay, followed by Chinese, Orang Asli, others, and also Indian. Okay, so the type of preschool we went was Tabika Kemas, which actually is a government preschool for low socioeconomic background, for children with low socioeconomic backgrounds, followed by private preschool around KL area. Okay, so the vision screening result shows that around 11% failed in distant vision screening in one eye, followed by 6% failed in both eyes. For the near one, 6.1% failed in one eye, followed by 3% failed in both eyes. And lastly is the stereo acuity, around 2% of the 435 children failed in their stereo acuity. So for someone who failed in at least one of the vision assessment is considered failed vision screening. So around 14.7% children failed in their vision screening. Okay, so for the VMI, we did the BB-VMI and we categorized the raw. First, we convert the raw score into standard, and then the standard score we categorize into 3 groups. So we have the average, below average, and the above average. The important thing is the below average. Around 10% children who fail their VMI. So this is actually alarming. So the mean VMI is 100.42, which is actually normal compared to the normative, which is 100. Okay, so for the first objective was to see if there is any difference of the BB-VMI scores of children who fail and who pass. And Mann-Whitney analysis shows that there is no significant difference because the P is 0.56. And then the image shown is basically just an example of below average VMI children who cannot even complete a triangle properly, and the average can even complete or can copy more complex shapes. The second objective was to determine the effect of reduced visual function towards the performance of VMI preschool. among preschool children. Okay, so we want to see whether a child who failed in the vision screening, what are the chances of them to also have an impact towards the performance of their VMI skill. And it shows that using the multinomial logistic regression with the three category VMI category, we found that around 1.77 times more likely to score below average for the children who failed in the vision screening. Okay, for the adjusted model, is adjusted based on the gender and ethnicity. Okay, for discussion, okay, so we found that from our screening, from our research, from our study, we found that around 15% children fail vision screening, which is actually kind of considerable amount, and they should have as soon as possible correct their vision with glasses and so on. And for the 10% should also be referred to do a training for the visual motor integration delay. And then for children who have good VMI or vice versa, for children who have good vision may fail their VMI or vice versa. And just to wrap it up, to ensure a child's school readiness, both visual function and VMI are basically independently important enough to ensure the child's school readiness. Okay, that's it for me. Thank you so much for listening to my presentation. I wish you all good luck. Thank you so much.
All right, thank you, Naufa, for the presentation. So now we open for a Q&A session. Any question from the judges?
Okay, thank you, Naufa. So from this 400 plus preschool children, they have DVA and VA and stereo. Any of them with both problems or all three problems?
Yes, there is some of them with all the three failed the three vision assessment. Some of them failed distance and near, and mostly majority of them failed distance.
Okay. So you propose to have the visual tests and BMI to be as a screening tools. So what about the visual? Are you going to, from your findings, can you propose to have all three as a screening? Because now
Yes,
we're doing the
absolutely.
first one, then.
Yes, because vision function is actually regularly being done, but only the distant vision for government school. So we propose, because of the importance of both distance, near, and also stereo acuity, so we propose to do all the three assessment whenever a vision screening is conducted.
Just that you have a good research problem about the visual acuity and so on, but it's not reflected in the result because you lump sum everything, you know. The fail is either one of the three. You need to detail out the three visual acuity towards BMI. Then only you can see any significant difference, any association, then only you can propose the screening. That part tu je lah yang lacking a bit. It's a good problem, but it's not reflected in the result. Okay, right. Thank you.
Thank you, Naufa, for your presentation. So my question is to correct the impaired visual function, right? So you have three different problems, right? One is like the distance vision and things like that. So then some of these can be corrected by wearing glasses. Like for example, for the stereo or city or something, how can you rectify the problems with children having this problem?
So usually stereo acuity, it usually be corrected with wearing glasses also. There is no actually like a manual treatment for the stereo acuity. If it's like very severe, then there's training that can be done But usually if they have failed in their vision screening in the stereotacticity, they should wear glasses.
Yeah, and as for your Beery VMI test, right? So this kind of test is designed by, is an international kind of test,
Yeah,
or you
international
designed by?
test.
Okay, so
International
then,
test.
yeah, so then would it be meaningful to test those children who have rectified their visual function? Let's say if they, after they wear the glass, does that improve their VMI as well?
Yeah, we wanna see, because it's actually a different skill, because that is vision and this one is like vision and motor, how well they coordinate each other. So if that test can be included in any vision screening, that would be really helpful for the future, for the children.
Yeah. So you do you suggest that the impaired visual function result in the impaired VMI as well? I mean, what is the relationship? Because if they
based on our research, we do not see any
it's not significant.
that is not significant. However, there is like 1.77 chance of someone failing in the vision will also fail in the VMI. So if can detect both of them, that would be really helpful.
No, it means that they cannot see, that's why they cannot, it doesn't work for them.
Yeah.
Okay, okay. I thought there's a, okay. Thank you very much. Yeah.
All right, thank you very much. So now we shall move on to the next presentation by Chin Kok Yong with the title Comparison of Chondroprotective Potential between Annatto and Palm Tocotrienol using SW1353 chondrocytes.
Good day, ladies and gentlemen. Today, let's discuss about a project entitled Comparison of Chondroprotective Potential between Annatto and Palm Tocotrienol using SW1353 chondrocyte. My name is Chin Kok Yong from the Department of Pharmacology, Faculty of Medicine, University of Bahasa, Malaysia. As an introduction, osteoarthritis is a joint deterioration disease triggered by mechanical stress, leading to a vicious cycle between cartilage breakdown and joint inflammation. During the inflammatory process, the chondrocyte viability and function will decrease, leading to decrease of cartilage synthesis. Osteoarthritis is characterized by joint pain, joint swelling, and also joint stiffness, and it affects 22.9% of population aged 40 years and above worldwide. If this condition is not managed properly, the end state osteoarthritic patient will have to undergo costly and invasive total joint arthroplasty. As of now, the pharmacotherapy of osteoarthritis is focusing on symptomatic treatment. This involves the use of analgesic like NSAID and paracetamol, and also intraarticular injections of corticosteroid and also hyaluronate. As of now, disease-modifying treatment agent for osteoarthritis is lacking in the market. In our previous study, Annatto tocotrienol and Palm tocotrienol has been shown to have a potential joint protective effect individually in a study by Chen et al. Supplementations of Annatto tocotrienol at 100 mg per kg in rats with osteoarthritis could decrease the joint deterioration in rats. In a clinical trial by Hafla et al., Palm tocotrienol at 400 mg in patients with osteoarthritis can increase their joint function and decrease joint pain in these patients. However, some research gaps remained, whereby there is no comparison between chondroprotective efficacy between Annatto tocotrienol and Palm tocotrienol, and there are limited studies on the chondroprotective mechanisms of tocotrienol at this moment. So we are not sure which is better and how tocotrienol can prevent osteoarthritis. This brings forth the research question of this study: which tocotrienol mixture is more effective in protecting chondrocyte, and what is the chondroprotective mechanism of tocotrienol? The objective of this study is to compare the efficacy of Annatto and Palm tocotrienol in protecting chondrocytes stimulated with monoiodinoacetate MIA and determine their mechanism of action. We hypothesize that Annatto tocotrienol is more effective than Palm tocotrienol in protecting chondrocytes stimulated with MIA, and the main mechanism involved is the suppression of chondrocyte differentiations and also oxidative stress. The methodology of this study can be divided into several steps. In the first step, SW1353 human chronocytes were treated with pumped tocotrienol and tocotrienol for 24 hours, and we use MTT to select the non-cytotoxic concentration range for tocotrienol. We observed that for tocotrienol, concentration below 30 microgram per milliliters, and for pumped tocotrienol, concentration range below 100 microgram per milliliters were non-cytotoxic. In the second step, SW1353 chronocytes were treated concurrently with MIA and also pumped tocotrienol or tocotrienol for 24 hours, and we use MTT to select the protected concentration range of tocotrienol. We observed that tocotrienol at the range between 10 to 20 microgram per milliliters and pumped tocotrienol between range 25 to 50 microgram per milliliters were effective in preventing the suppression of viability of cell due to MIA inductions. In the subsequent steps, ELISA were used to measure the level of 8-isoprocent F2-alpha level, a stable lipid protection marker in chronocyte simulator with MIA. We observed that with MIA simulations, there is multifold increase of 8-isoprocent F2-alpha level in the chronocyte. With the additions of pumped tocotrienol at 50 microgram per milliliters and also tocotrienol at 10 to 20 microgram per milliliters, the increase in 8-isoprocent F2-alpha level were moderated. In the next step, SW1353 chronocytes were treated with MIA and pumped or tocotrienol concurrently for 24 hours. ELISA kits were used to measure the protein expressions of chronocyte health markers such as collagen 1-alpha-1, collagen 2-alpha-1, erican and SOX9, and also ADAM-TS4, which is a metalloproteinase. We observed that with the additions of MIA, there were significant decreases in collagen 1-alpha-1 and also ADAM-TS4 level. This indicates a loss of functions for the chronocyte. However, the other chronocyte health markers such as collagen 2-alpha-1, erican and also SOX9 were not significantly affected by MIA, and this could indicate that the cellular reparative mechanism of the chronocyte was still retained. The additions of tocotrienol in the presence of MIA actually improved the protein expression of collagen 2-alpha-1, which subsequently increased the ratio of collagen 2 to collagen 1 in the chronocyte. At the same time, the core incubations of tocotrienol and also MIA also increases the erican and also SOX9 level in the chronocyte. This indicated that tocotrienol can increase the chronocyte reparative mechanism challenged with MIA. As a discussions, the additions of MIA can increase the stress level in the chronocyte as indicated by increased 8-isoprocent F2-alpha level, and this will lead to 2 cell fate. If the cellular additive repair mechanism is activated, then the viability of the chronocyte will increase. If this mechanism fails, then the viability of the chronocyte will reduce. The additions of pumped and tocotrienol can reduce the stress level in the chronocyte. In addition, the supplementations of tocotrienol can activate the cellular reparative mechanisms, leading to increased SOX9, collagen 2-alpha-1, erican level, and this will enhance the viability of the chronocyte. In our ongoing study, we have been supplementing tocotrienol and pumped tocotrienol in rats with osteoarthritis. Using the result of serum cartilage oligomatrix protein level, serum COM level as an example, we show that the intraarticular injections of MIA can increase the serum COM level, indicating active cartilage degradation process, and the supplementations of tocotrienol at 100 to 150 mg per kg and pumped tocotrienol at 100 mg per kg with or without the additions of glucosamine can actually decrease the serum COM level, indicating a terminations of the cartilage degradation process. As a conclusion, tocotrienol is more effective than pumped tocotrienol in protecting chronocytes stimulated with MIA. Both anatocotrienol and palmitocotrienol exert antioxidant effect on the chondrocyte. In addition, anatocotrienol can also increase or stimulate the repair mechanisms in damaged chondrocyte. This is the end of our presentations. We'd like to thank Ministry of Education Malaysia for funding this study by FRGS grant. With that, thank you.
All right, thank you very much for the presentation. So now we open for a Q&A session. Any question for the judges?
Okay, thank you. Okay. That you go ahead first. Go ahead. We cannot hear you. That you?
Yeah, Dr. Lau, we cannot hear you. So maybe Prof. Fazila can start first.
Okay, thank you, Ko Yong Chin. So I realized in the introduction just now, the pump PT3 have been used in human, right? That's reduced. It has effect in human. Is entity already used in human subject? Is it available?
Okay. Good morning, Prof.
Right.
So I hope you can hear me. So in the palm tocotrienol study, so it has been tested in an open label clinical trial, and it has been shown to reduce the WOMAC score and also the pain score of the patients. And the product used is being produced in Malaysia. Whereas for ANTT, the anatotocotrienol, the product itself is not available in Malaysia, and it has not been tested in humans so far for osteoarthritis.
I'll be interested.
Yeah.
For many.
Wait until I complete the human study, Prof.
Sure, I'll wait for it. Thank you.
Is there a question?
Dr. Lau, I think we still cannot hear you.
I will fix it now.
Yeah. Dr. Lau, can you? I can't hear a question, so perhaps you can type it in the chat.
You?
Yeah, maybe Dr. Lau can ask the question in the chat box while we move on to the next presentation.
I can hear you now.
I changed.
Yeah,
thank you, Dr. Chin, for a very nice presentation. So my question is, how difficult is that to change, to modify the structure of tocotrienol from the palm oil to that of the anato?
Okay, thank you for the questions. So basically, the difference between palm tocotrienol and another tocotrienol, the difference does not lies with the structure, but it lies with the compositions. Okay. So for palm tocotrienol, it has around 25% of alpha tocopherol, 25% of alpha tocotrienol, 30% delta tocotrienol, and the rest is beta and delta tocotrienol. But for another tocotrienol, it is naturally produced without any alpha tocopherol, and it is very high in the compositions of delta tocotrienol, which is almost 90%, and the rest is gamma tocotrienol without other isomers. So if we want to modify, let's say, the palm tocotrienol compositions into something like another tocotrienol, which is without alpha tocopherol, then it involves a further extraction process. From my knowledge or from my conversations with the supplier of the tocotrienol, because tocotrienol itself is not very cheap, so we've added the extraction process. It might not make the product not economically viable for the general public because it's very expensive. So why would we interested in removing the alpha tocopherol? Because in our body naturally have a preference to absorb alpha tocopherol. So in doing that, it actually reduces absorptions of tocotrienol. So that's why having a natural pure tocotrienol mixture like annatto is preferable.
Yeah. So where can we get this annatto?
Interesting fact, annatto tocotrienol is available. Annatto plant itself is available in Southeast Asia, but it is not used commercially in Malaysia. I traveled to Thai and also to Philippines, and the farmers there actually planted annatto trees and extract the oil for their cooking.
Oh, okay.
Yeah, but just it's a sad fact, like it's not found in Malaysia.
and another question is about has anybody worked out the molecular mechanism how this tocotrienol actually confer its protective function to this chondrocyte?
Yeah. So I think we are the first one to actually study the effect of tocotrienol on chondrocyte and the disease of osteoarthritis. So we are still pursuing these research questions.
So the molecular function hasn't been quite worked out yet, although
yes.
the biological the functions in terms of how it protects. Yeah.
The internal signaling pathway has not been worked out yet. It's just that we realize that when the chondrocyte is damaged, when we treat it with tocotrienol, it seems to activate the rescue mechanism, but the internal signaling pathway has not been worked out yet. Yeah.
Thank you very much. Thank you very much. Interesting.
Yeah, thank you.
All right, thank you very much. So now we shall move on to the next presentation by Lim Ming Ming with the title Development and Validation of Early Intervention Guidebook in Bathing or Showering for Children with Autism Spectrum Disorder.
Good morning, everyone. My name is Lim Ming. I am from Occupational Therapy Program, School of Rehabilitation Sciences, Faculty of Health Sciences, University Kebangsaan Malaysia. Today, I'm going to present my research with the title, The Development and Validation of Early Intervention Guidebook in Bathing or Showering for Children with Autism Spectrum Disorder. Children with autism often exhibit significant impairment in social, occupational, or other important areas of current functioning, which will affect their ability to learn and performance skill while carrying out daily activities such as bath time. These findings were based on Cardot et al. 2011, Floss et al. 2014, Kling et al. 2010, and Langone et al. 1999. Children from 18 months to 36 months spend most of the time with their parents. Therefore, parents play a primary role in teaching their child the bathing or showering skills. Hence, a valid bathing or showering guidebook for children diagnosed or suspected with ASD is crucial to facilitate independent bathing or showering among them. This study aims to develop and validate an early intervention guidebook in bathing or showering for children with ASD aged 18 months to 36 months in Malaysia. This study is a cross-sectional mixed method study. For the inclusion criteria, this study included occupational therapists, special needs and early education and lecturers with at least 5 years of working experience in pediatric settings, and parents or caregiver of children diagnosed or suspected with ASD and without other disability. This study excluded occupational therapists, specialists and education, and lecturers, and also parents or caregiver of children diagnosed or suspected with ASD who do not understand Malay language. This is because this bathing or showering module was in Malay language. The participants enrolled in this study were occupational therapists, specialists and early education and lecturers with OT backgrounds and have at least 5 years of working experience in pediatric settings. And also parents or caregivers of children diagnosed or suspected with ASD and without other disability. The outcome measurement in this study were qualitative survey form, content validity form, and also interview-based questions. The procedure of this study were the content domain of this early intervention guidebook was identified firstly by literature review. The 5 domains were introduction, problem usually faced by children with autism, strategy that can be used to help children with autism, suggestions to promote involvement of children in bathing or showering, and safety measures during bathing activity. After that, this newly developed early intervention guidebook in bathing or showering was tested its validity through evaluating by 9 participants with OT background through focus group discussions, FGD. Through the FGD sessions, 4 teams were generated based on panels' feedbacks and suggestions, which were appropriateness of terminology, appropriateness of contents, arrangement of contents, and physical appearance. For appropriateness of terminology, panel suggested to change the word of module to buku panduan, as module is too formal. They also suggested to include target population, which is parent at cover page for clearer image. For appropriateness of contents, experts suggested to include more explanation about the objective of the guidebook and why their children need to be independent in performing the specific activity. To include more information on how and when to use the guidebook at the Prakata part. For arrangement on contents, experts suggested to tally between the problems listed occur in children with autism in bathing or showering and the strategies. Whereas for the physical appearance, experts suggested to change the picture of adult male and female at cover page to children. Add on related pictures such as 9-feet mat and bathing ducklings. Use more graphic mind maps, graphic tables, and element instead of lengthy wordings. After that, the revised early intervention guidebook was distributed through online for the expert panels again in order to rate the 5 items in this guidebook in terms of relevance, clarity, simplicity, and ambiguity. The Content Validity Index, CVI, was computed for each item in each skill as well as for the overall skill, which is SCVI. Kappa was used to determine the inter-rater agreement. 5 participants for the cognitive interview were asked whether the instructions provided in the guidebook could be easily understood. Their feedbacks were recorded and teams were generated for further notifications. Now move on to the result. This table shows that ICVI and SCVI are averaged on a 5-item scale for 4 domains, which were relevance, simplicity, clarity, and ambiguity. The ICVI for all items and all skills was very high, which was ICVI more than 0.76, with the modified kappa agreement among the rater demonstrating excellent agreement, which was K more than 0.76. The SCVI was high for all skills, which were relevance and simplicity. SCVI was equal to 1.0. And for ambiguity and also clarity, the SCVI was equals to 0.98. After that, 3 participants were included in the cognitive interview. Based on the cognitive interview, 2 themes were generated, which were physical appearance and appropriateness of chosen methods and contents. For physical appearance, parents commented that the font size, font style, and the cover page graphic were appropriate. They were more interested and preferred in color picture instead of plain black and white pictures. They suggested to put pictures at the introduction of the activity in order to make it more interesting and graphical. For the appropriateness of chosen methods and contents, parents suggested to put some motivation and positive quotes throughout the module as an element to enhance positive energy for parents to keep on trying and training even though it is hard. They also suggested to bold each keyword or important words in this early intervention, bathing or showering guidebook. They also suggested to insert real pictures of the suggested tools to promote involvement of children in bathing or showering. For the conclusion, this newly developed early intervention guidebook is valid for health practitioners to refer to during treatment. Parents who have children diagnosed or suspected of ASD could also use when training their children's bathing or showering skill. That's all from me. Thank you.
All right, thank you, Min Min, for the presentation. So now we open for the Q&A session. Any question from the judges?
Yeah, thank you, Min Min. Oh, just now was dressing, now it's bathing. Okay, let me clarify. The mother's part is the content, cognitive interviews and the thematic that came up from it is for the development part of the content validity part.
For the cognitive interview is after the development part and after the content validity part.
So for, okay, coming back to content validity, it was FGD among 9 experts, right?
Yes.
Experts, what were the trigger question that you gave them to come up with your to conduct FGD? You need to give them triggers, right? And then what were the themes that came up from this discussion?
For the FGD sessions, the questions that triggered for the FGD sessions were how was the appropriateness of the content and whether the experts understand the whole content about the bathing or showering guidebook, and is there any terminology that is not appropriate for this early intervention guidebook, because this early intervention guidebook will distributed to parents later. So the terminology used should be more layman term and should not be too professional. And the themes generated for the FGD sessions were the appropriateness of terminology, the appropriateness of content, and the physical appearance, and also the appropriateness of the appropriateness of terminology, the appropriateness of content, and also the physical appearance.
See, what I meant is, yes, the appropriateness, but what I mean, what is the actually the content inside the guidebook? Let's say, can they use shower gel? Can they use bar soap, something like that? How do you come up with that? That content itself, do you come up by your own or from the FGT itself?
Firstly, I developed this guidebook through some literature review. So I referred some guidebook from that developed in Malaysia, such as toileting guidebook, because there's still not yet any bathing or showering early intervention guidebook developed for bathing in Malaysia currently. So through some literature review, the 5 domains developed were the introduction, problem usually faced by children with autism, strategy that can be used to help children with autism, suggestion tools to promote involvement of children in bathing or showering, and also the safety measure during bathing activity.
Because FGT usually come up with different concept and different aim, but this is more like CVI, but it's okay. Thank you.
Thank you.
All right, so thank you very much. So now we have one last presentation here by Pang Kok Luan with the title Anti-Cancer Effects of N-ethyl tocotrienol, gamma tocotrienol, and delta tocotrienol on human chondrosarcoma cells.
Very good morning, everyone. My name is Pang from Newcastle University Medicine, Malaysia. Today, I would like to share some findings from a study which titled Anti-Cancer Effect of N-ethyl tocotrienol, gamma tocotrienol, and delta tocotrienol on human chondrosarcoma cells. This study was led by Dr. Chin Kok Yong from the Department of Pharmacology, UKM. As introduction, chondrosarcoma is a type of cartilage bone cancer, which naturally resistant to chemotherapy and radiotherapy regardless of low or high grade. Currently, the only treatment is via surgical removal of cancerous tissue. On the other hand, N-ethyl tocotrienol, in short, NTT, is extracted from N-ethyl beans. NTT is unique in terms of composition as there is a high level of delta tocotrienol and 10 to 16% of gamma tocotrienol. Currently, the anti-cancer effect of NTT, delta and gamma tocotrienol on chondrosarcoma remain unknown. Therefore, in this study, we aim to determine the anti-cancer effect of NTT, delta and gamma tocotrienol on chondrosarcoma cells. Experimental design. SW1353 cells was used and treated with NTT, delta and gamma tocotrienol for 24 hours under the cytotoxicity study or 72 hours for anti-proliferation study. Upon determining the IC50 value, the following parameters were conducted, including in more cell death, cell cycle analysis, and also morphological analysis. Result and discussion. From the MTT assay, NTT, delta and gamma tocotrienol significantly reduced the variability of SW1353 cells in concentration-dependent manner. Based on the IC50 value, delta tocotrienol is the most potent isoform, followed by NTT, the mixture, and gamma tocotrienol. From the more cell death study, NTT, delta, and gamma tocotrienol induce significant cell death, mainly apoptosis, shown by the green colored bar, upon 48 hours treatment, but not 24 hours of treatment, despite the IC50 of 24 hours treatment was used. So in this study, we speculate that during 24 hours of tocotrienol treatment, it did reduce the viable number of cells, but not until the significant cell death. Subsequently, 2 more experiments was conducted to confirm our speculation on growth arrest. First is via the anti-proliferation study. From the result, it shows that NTT, delta and gamma tocotrienol were anti-proliferative by reducing the proliferation of SW1353 cell along the 72 hours of treatment. Based on the IC50 value, similar to MTT assay, delta tocotrienol is the most potent isoform, as followed by NTT and also gamma tocotrienol. Subsequently, we conduct the cell cycle analysis, and it shows that NTT, delta, and gamma tocotrienol induce a G1 arrest upon 24 hours of treatment. Last but not least, for the morphological analysis, NTT, delta, and gamma tocotrienol cause the morphological changes upon the treatment, whereby the cells, the SW1353 cells, change from a typical fibroblastic appearance to become squamous-like or irregular in shape. Occasionally, during the 24 hours treatment, we detected some cytoplasmic vacuole formation, as shown by the arrowhead. And also, the cytoplasmic vacuolation become more prominent during the 48 hours of treatment. In this study, the cell death with massive vacuolation upon the treatment may relate to peroptosis or peroptosis-like cell death. So what is peroptosis actually? Peroptosis is a less common subtype of programmed cell death. However, clinically it's important as it is effective against apoptosis-resistant and multiple drug-resistant cancer. As discussed earlier, one of the key features of peroptosis is the presence of extensive cytoplasmic vacuolation, and the entire process is independent to the claspases activation. However, currently, based on our mode of cell death study, by using the NSM5C FITC PI staining, we are unable to distinguish between the peroptosis and apoptosis because both of the cells, they're having the intact membrane and positive with the apoptotic marker. Additionally, previous study shows that delta and gamma tocotrienol were reported to induce peroptosis in several cancer cells. So this is an example of picture from a previous study, whereby the delta tocotrienol induced peroptosis and vacuole formation in the prostate cancer cells. And this is the image from our study. Nevertheless, further study is required to confirm the peroptosis on SW1353 cells upon the tocotrienol treatment. In conclusion, NTT, delta, and gamma tocotrienol induce a G1 arrest on SW1353 cells in the early phase of treatment, which progress to apoptosis upon 48 hours of treatment. Additionally, tocotrienol also induce massive cytoplasmic vacuolation, which may relate to peroptosis or peroptotic-like cell death. We acknowledge the Malaysia Ministry of Education for the FRGS funding, and we also thank the Department of Anatomy and the Department of Biochemistry, Faculty of Medicine, UCAM, for providing the research facility. This is a reference for the presentation. Thank you.
All right, thank you for the presentation. So now we open for the Q&A session. Any question for the judges?
So thank you, Dr. Pang, for your very interesting presentation. So I think this project is related to Dr. Gabriel Chin's project as well, right? This Anato tocotrienol. So my question is, I'm starting to get a little bit confused because both of you are using the same cell line, right? This SW1353 and chondrosarcoma cell line. So for Dr. Chin's studies, what happened is he found that this Anato tocotrienol has a protective effect on the oxidative stress of the the osteoporosis. I can't remember that, but it has a protective effect against the MIA treatment. But then for your case, at a certain dosage, this Anato tocotrienol can actually kill the cancer cells by inducing apoptosis, right? So let's say if what are the dosage, what are the dosage if let's say this supplement is given to the patient, what are dosage that can induce this protective effect and what is the dosage that can actually kill the cancer cell? So I think, is there, what are the actually the dosages? Yeah.
Thank you, Prof. Can you hear me?
Yeah, I can hear you.
Yeah, thank you, Prof, for the question. In fact, let me clarify on the differences between these two projects. For the Dr. Chin presentation just now, actually we are using a much lower concentration. If I'm not mistaken, for Ananto, it's 5 and 10 microgram per ml. And yeah, palm tocotrienol is different compound. So for our for the study that I present just now, we tested the cytotoxicity of the compound on these cells up to 50 microgram per ml. So, and the IC50 in fact is far more higher. Yeah, right. So yeah, first thing is on the difference of concentration, and in terms of until the supplementation or until the human population, I based on the current study and findings, I can't really tell what is the precise recommended dosing. Based on the previous study on human, if I'm not mistaken, it is safe up to 400 milligram per day, or sort of that concentration, but I can be wrong. I'm not that sure. But it is too early for us to mention what is the effect of just based on our current study, because there is no any previous study conducted on control sarcoma. So simply based on our IC50 from cell culture or in vitro data, I can't really tell what is the precise dose.
So based on your study and Dr. Chin's study, there is obviously a two different regime. There's very low concentration for the protective effect and the very high concentration for the apoptotic effect on the cancer cell, right? Yes. So my another question is, because you're only using the SW1353 to test the anti-cancer effect of this Anato compound, my question is, if such a high concentration can also kill healthy cells and also like other type of cancer cell, is the killing of this chondrosarcoma something that is specific, or at this concentration it can kill virtually any type of cells? That is, whether it's the toxicity just because it's toxic. Yeah.
Thank you, Prof, for the question. So again, this is a preliminary study from our group, and first thing regarding the selectivity of this compound, current IC50 for, let's say, Ananto tocotrienol, gamma and delta is around 19.5 to 38.5. I mean the range. There is a previous study from our team as well, conducted on Ananto tocotrienol, tested the cytotoxicity on pre-osteoblast MC3 T3 cells whereby, if I'm not mistaken, the IC50 is higher than 50 microgram per ml. So in other words, it's quite selective on cancerous cells. And of course, based on the current presentation, the data that we shows, we can't really tell that how effective of these nanto or gamma and delta tocotrienol on other cancer cells. And we did have a further study on the potential underlying mechanism, and we did do the transcriptomic profiling and found that there's a lot of cell cycle related gene is upregulated. ER stress related gene is upregulated as well, and all those autophagy genes. So we haven't confirmed that this particular pathway is involved in along the tocotrienol induced cell death, but just that highly suggested ER stress, autophagy, and also of course cell cycle arrest is involved in this part of a mechanism.
And then the palm oil tocotrienol actually don't have this anti-cancer effect on.
I think we do perform the testing, and the IC50 is far more higher. But we didn't further venture into the molecular mechanism, the pathway, the cell cycle arrays, and so on. I think we just do until the 24 hours of cytotoxicity, and the IC50 is far more higher.
Thank you very much.
Thanks.
No, I don't have any further questions.
Thank you.
All right. So if there's no more question, then I think we have come to the end of our session for today. So thank you very much for all the judges, the presenters, and also the audience. So we'll be selecting 3 Best Presentation Award winners based on the marks given by the judges. And the result will be announced tomorrow on this Minggu Penyelidikan website. And the secretary will also inform the winners personally. So thank you very much again for attending this session today. I hope that you have learned something useful through the presentations and also the Q&A sessions. So thank you very much and see you again.
Thank you, Dr. Tan. Thank you, Prof. Thank you all.